morning, Romania. How are you? Bun venit, bun venit.
From Bucharest, we'll go to New York and I'll introduce Dr. Barry Smith. He's the Director of Clinical Simulation Education.
We don't practice on our patients. We practice on high fidelity mannequins.
I'm going to just go into the intro to mechanical ventilation. Some of the topics that we'll discuss today is starting with oxygen therapy.
Learning is always a two-way street. That's one of my quotes I tell the residents. Sharing of information is key in medicine and in life. And this is what the waveform looks like. This is a mechanical breath. You can see it's identical and identical. And here we can see that these are spontaneous breaths. Right? And you can see where it's triggered, the negative deflection before the breaths.
Excellent presentations. Thank you. That's all. We are good for now.
Thank you so much.
Waiting to apply on your simulation program right now. We have a lot of knowledge.
Then it is the total volume divided by change of esophageal pressure. And if you want to separate out the lung and then measure the compliance, then it's going to be total volume divided by blood pressure minus P minus change of esophageal pressure.
My goal is to give you a much more practical, granular, close to the patient type of a talk. There are basically 3 steps to liberation from mechanical ventilation. First one is readiness testing. Recognize who's ready for a trial of liberation from mechanical ventilation.
I want to introduce Dr. Oswald Murray. He's the Director of Respiratory Therapy.
The data actually demonstrate or show us what we need to improve on, areas we need to work on, and we also share that information with the multidisciplinary team.
The purpose of simulation is to practice in a safe space. So answers could be incorrect, correct, we don't care, because in the end of the day, we all learn from each other.
On the ventilator itself, at the bottom, is where all the settings are placed.
Patient is speaking incomplete sentences. Respiratory rate is 26 and labored. Blood pressure 170/60, and respiratory rate 25. His EKG shows sinus tachycardia, and this is his initial chest x-ray. Respiratory intercostal retractions, abdominal breathing, nasal flaring. He looks overall very sick.
They want to increase the volume.
If oxygenation was an issue and you gave the recommendation to go up to 8, you guys did 20/8. You actually accounted for the pressure support, which was good.
Okay, I-Team 3.
Doc, I'm having an issue. The saturation is dropping. As I listen to breath sounds, I hear wheezing, I hear rhonchi. The patient is desatting. He's 87 now, his heart rate is 130.
Increase the volume to 100%. You try to pass the suction and you're not able to pass the tube?
No, I passed the suction, but I didn't get anything. But I still hear the wheezing, I still hear the rhonchi.
Sure.
The suction was able to go through.
You can have a bronchoscopy.
That's the morning chest x-ray. Let's go to the vent, which is alarming.
Okay, so if you take a look, you notice how you have high peak pressures, and you heard an alarm, so it's alarming airway pressure high, right? So what are some things that you would want to assess on the ventilator? So now you've given the patient more exhalation time, and now they're having more time to exhale the CO2.
Good job, doctor. So you increase exhalation time. Very good, Team 3. All teams, you did a great job. Just go around telling us how you felt about the simulations. Dr. Theo, we thank you. And I want to thank all our pulmonary critical care intensivists.
It was a very, very nice day for us and a very new experience.
And a big thank you from all of us here. Great.